Good evening, everyone. How are you all? Excuse me. All right. So tonight we are going to start with your GIT system. So I'm a little bit still. I'm coming around because I caught a flu, and so excuse me if I'm talking a bit slow today, and also not quite loud, and also if I give a cough. Okay. So we are going to do GIT today, and GIT is a bit complex. There's a lot of things which comes from here. So we'll need to go through this in two classes. All right. So let's start our GIT system. So first of all, we'll just have a look on the basic pathophysiology of GIT system. So let's have a look to this video.
Digestion in human beings. Human beings take food through mouth and digest it in specific organs for digestion. The undigested food is defecated. The food we take passes through a specific canal which begins with buccal cavity and ends at the anus. This canal is called alimentary canal or the digestive tract. The parts of the alimentary canal are buccal cavity, esophagus, stomach, large intestine, small intestine, rectum, and anus. The food gets digested gradually as it passes through the various parts of the tract. Digestive juices secreted by the salivary glands, liver, and pancreas also aid digestion. Mouth and the buccal cavity. Food intake in human beings is through mouth. This process of taking food is called ingestion. Chewing food is very necessary for proper digestion as digestion process starts in the mouth itself. What happens during chewing? The large pieces of food we eat are mechanically broken down into small pieces. Teeth helps us in doing so. Action of saliva on food. During chewing, food mixes with saliva. Saliva is secreted from salivary glands located on the lower jaw between the tongue and teeth. Saliva converts starch in the food into sugars and also softens the food.
Okay, let's say that now all of you know these things, but still it's just kind of a good video to have to remember things that you might have forgotten.
The peristaltic movements of the esophagus helps the food to move down the tract till it reaches the stomach. Stomach. Stomach is a bag-like structure with thick wall. It is in the shape of a flattened U and is the widest part in the alimentary canal. The food that enters the stomach is churned and mixes with the mucus. Hydrochloric acid and digestive juices secreted by the inner lining of the stomach. The acid helps to kill the bacteria present in the food. It also makes the medium in the stomach acidic. The digestive juices secreted by the stomach break down proteins into simpler substances. Then the food is emptied into small intestine. Small intestine. Small intestine.
Okay, so you can go through this video by yourself. So basically what happens, all of us know that. So it goes to the intestine and then it comes out through the rectal and anal area.
Is
So you can have a look. Let's move on with our topic today. So these are all the chapters of GIT. So you can see there is a lot of things to discuss. The main chapter, so this on the right hand side, the chapters that you can see, these are from JM 8th edition. So abdominal pain is the most important out of any of them, and our main focus tonight will be this. Then chapter 26 has anorectal disorder, which we discussed in surgical class. We will discuss constipation, diarrhea, dyspepsia, dysphagia, hematemesis, melena, and jaundice. All right, so these are all the GIT chapter that we need to cover. Now for abdominal pain, we mainly take it from John Muttag. So if you guys open John Muttag chapter 24, then you'll be able to see this. So we'll discuss this chapter from John Muttag. So abdominal pain, what is the commonest cause of acute abdomen in a general practice? The commonest cause of acute abdomen in a general practice is acute appendicitis, followed by colic and mesenteric adenitis. So sometimes this kind of question comes that what is the most common cause of acute abdomen in general practice? So you can go through these key facts and checkpoints in your own time. And in here you can see some of the acute abdominal pain causes, which we will discuss in no time. So the initial things I would advise you guys to just read it once if you can. Read what are the red flags, some of the dangers. So these things are not super important. You can read it in your own time. We will move on to the specific topics. So I will advise all of you, because this is a super important chapter. You have to read John Muttag in detail. So read everything that is in here at least once. Okay, abdominal pain in children. So the common causes are infant colic, gastroenteritis, appendicitis, mesenteric adenitis. What is infant colic? Infant colic is very common. You get this kind of like inconsolable crying in a child between 2 weeks to 16 weeks of age. So this is usually found in a well baby who cries like unexplained periods of inconsolable crying and fretfulness. So quite irritable crying start at the late afternoon and evening and last for hours. So this is what we call as colic. So clinical feature, baby between 2 to 16 weeks, prolonged crying at least 3 hours, occurring at least 3 a week, crying worst at around 10 weeks, start during the late afternoon and early evening, but everything seems to be fine. So on physical exam, everything will be normal. So nothing needs to be done. You just reassure the parents that this is quite normal and it will get better. There are no need of any medication for this. Intussusception, we discussed intussusception in our pediatric class, so we will not discuss it anymore. Appendicitis in children. So I think we discussed this in one of our question solved class, that how to differentiate appendicitis and mesenteric adenitis, right? So go through these things. So what is the difference between appendicitis and mesenteric adenitis? Always remember that mesenteric adenitis is followed by a recent upper respiratory tract infection. They get high fever. The pain can be in either right or left iliac fossa. Okay. And there can be very minimal guarding and usually no rigidity. That's usually one of the important findings that helps us to differentiate between appendicitis and mesenteric adenitis. Because appendicitis, there might not be very high fever, there will be no upper respiratory tract infection, and usually patients will come to you with anorexia, nausea, vomiting, followed by abdominal pain, which starts in the umbilicus and radiate to the right iliac fossa. But most importantly, the children will be having tenderness on the right iliac fossa and guarding and rigidity. So guarding rigidity is very common in appendicitis. Okay, so there is usually what we do that if we are not sure that if it is appendicitis or mesenteric adenitis, we send the child for an ultrasound, and ultrasounds are pretty good to differentiate between these two. And sometimes you can do full blood exam and you will see that their WBC count is quite high. There is a condition called recurrent abdominal pain in children. So you can go through this in your own time. It's not very important. Moving on to abdominal pain in elderly patients. So now your main adult GIT starts. So abdominal aortic aneurysm. So all of you know what is aortic aneurysm. So aorta is the biggest blood vessels in our body. It starts from the heart, and then when it starts from the heart, it is what we call as thoracic aorta. That means the aorta which is in your chest. And then aorta goes down to the abdomen, becomes abdominal aorta. So if the abdominal aorta, if the diameter of aorta gets increased, that's what we call as abdominal aortic aneurysm. So what is the normal diameter? The normal diameter is less than 30 millimeter. Okay, so that means less than 3 centimeter. So we say that on an average, between 10 to 30 is the normal diameter of the aorta. When we call it aneurysm, aneurysm is called when the abdominal aorta diameter is more than 30 millimeter. Now, if it is 30 millimeter, it is still not that much risky. So what actually happens in this kind of condition is that, let's see if this is the heart, and abdominal and the thoracic aorta goes like this, and then there is abdominal aorta. So in aneurysm, it becomes dilated. When it gets dilated, the muscle gets very, very weak because it loses its elasticity and everything. So it becomes very weak, and sometimes if it gets enlarged, especially after 50 millimeter, so once it is more than 50 millimeter, the chance of rupture gets very high. So we say that if we get a patient who has got aortic aneurysm and it is more than 40 millimeter, then we send a referral to the vascular surgeon for them to have a look. So what they want to do they want to like repair it? Do they want to follow up the patient? So it will be dependent on the vascular surgeon what they want to do. But after 40 millimeter, you have to send a referral to the vascular surgeon. So most of the patient who has got abdominal aortic aneurysm, it is asymptomatic until it ruptures. Because once it ruptures, then it causes severe abdominal pain. Until that time, usually most of them will be asymptomatic. Some of them can have a bit of abdominal discomfort. And if it is a bit larger in size, you can even feel a pulsatile mass on the patient's abdomen. Family history is common. That's why we say that any first degree relative should have an ultrasound screening after 50 years. So if your patient has got abdominal aortic aneurysm, you will advise any first degree relative of that patient who is above 50 to have a regular ultrasound screening for any of these aortic aneurysm. Okay. So refer if more than 40, greater than 50 is significantly enlarged, and it is usually when it is becoming above 50 millimeter, then there is surgical indication that this has to be repaired. So how we investigate? If we suspect that the patient might have an abdominal aortic aneurysm, our first investigation can be an ultrasound. If ultrasound is not helpful or if it doesn't give us a clear picture, then best would be CT or MRI. So CT is the investigation of choice, and the best out of anything is MRI. Okay, so initially you can do an ultrasound if you suspect that there might be an abdominal aortic aneurysm, and then either CT or MRI, any of them would be best. If they give you what is the most definitive investigation, in that case, we go for MRI scan. Okay. Now, there is a guideline in RSCGP about this aortic aneurysm. So I want you guys to go through that as well. There is a bit of confusion in RSCGP about the referral and everything. Let's have a look. So you can go through this in your own time. Just read a little bit from here, but we will come on this part. Okay, so these are the risk factor of abdominal aortic aneurysm. So give it a read. And in here, they have written the risk of rupture. So they say that if it is more than 5, the risk of rupture in a year is 1 to 10%. So sometimes they ask this risk also. So try to remember it. Screening and surveillance. So questions come from this screening. The problem is that there are two kind of different kind of screening. So no one knows which one should be followed. But let's see. So according to the RSCGP, they say that if the aortic aneurysm, the diameter is between 3 to 3.9, then surveillance should be done every 2 yearly, 4 to 4.5, 12 month, 4.6 to 5 every 6 monthly, and above 5 every 3 monthly surveillance is needed. Surveillance usually will be done by an ultrasound. So this one comes in exam. Please try to memorize it. And these are the indication of abdominal aortic aneurysm repair. So you can also give it a read. Okay. And repair can be done either open repair or endovascular aneurysm repair. So these are the two ways of repairing. Nowadays, endovascular repair is more commonly done. Okay. So that's your abdominal aortic aneurysm. Now, what if it gets ruptured? So rupture aneurysm presents with a surgical emergency. Patient will present to you with an acute abdominal pain, and sometimes the pain can refer to the back. Along with that, patient will be in a significant circulatory collapse. So have a look that this is where the patient usually gets pain. So central abdominal pain, very sudden onset, traveling to the back, and patient is a bit elderly, sometimes even a known aortic aneurysm patient, and definitely when it is ruptured, patient will be in shock. If you get some patient like that, that patient needs to transferred immediately to the surgical theater, because this is one of the case where saving the patient is very, very hard. Okay, so ruptured aortic aneurysm means intense central abdominal pain, patient having the pain going to the back, and pain and shock. If that is the case, it can be a ruptured aortic aneurysm. You don't have any time to do any imaging or anything. You just take the patient to the theater. And definitely, while the patient is transferring, you need to insert an IV line, start the patient with IV fluid, and then send the blood for blood grouping, cross matching, and give the blood once it is available. So that's abdominal aortic aneurysm and rupture. Moving on to another condition of elderly patient, which is mesenteric artery occlusion. So there is a condition called acute mesenteric ischemia, acute mesenteric ischemia, it means that the superior mesenteric artery, which supplies the gut, let's see if they have got a picture. No. So the superior mesenteric artery, let's show you a picture. So you can see the superior mesenteric artery over here. So if somehow the superior mesenteric artery get blocked, so either it gets blocked by a clot, that means patients who has lot of atherosclerosis like hypercholesterolemia, previous cardiovascular problem. So a known atherosclerosis patient sometimes can have this kind of clot gradually building over months and months and years, and at some point it can get fully blocked. So if superior mesenteric artery get fully blocked either by a clot formation or an emboli can come from the heart and can block the artery. So who has atrial fibrillation, they are very prone to have a emboli like that. So if patient has got AF and then from that atrial fibrillation, patient had a emboli which has traveled down to the superior mesenteric artery and blocked it. That's the time patient will develop this acute mesenteric ischemia. So acute mesenteric ischemia, it is superior mesenteric artery occlusion either by an emboli or thrombosis. Atrial fibrillation is a very important clue to the diagnosis of this. The problem is that if superior mesenteric artery is blocked, then there will be no blood supply to some part of the gut where it is supposed to supply. So that part of the gut can get irreversible damage and it can die. Okay? And necrosis of the intestine can happen. So that's why it is also a surgical emergency. So how this patient usually presents? Patient usually will present with a central periumbilical pain. So the pain will be central periumbilical. Okay, just 1 second. So is it like no one can enter into the class after 100? Is that so? Oh, okay. Let me just increase the capacity. Just 1 second, guys. Sorry, I didn't know that it ran out. Ask your friends to join again now. It should be fine. I just increased the capacity of the meeting. Okay. So we are discussing about the mesenteric artery occlusion. So mesenteric artery occlusion, it happens because of superior mesenteric artery occlusion, either from a emboli or a clot. And atrial fibrillation is usually one of the cause of it. So patient will come to you with a central periumbilical abdominal pain. So there will be central abdominal pain, right? And patient usually, once it starts centrally, then gradually it becomes worse and worse. Patients sometimes have a fear of eating because many times this mesenteric ischemia, it gets worse after eating. So central abdominal pain, profuse vomiting, watery diarrhea, and sometimes bloody diarrhea. And at some point, patient can be in confusion. So again, if you know how this case usually presents, so mesenteric artery occlusion, the patient will be elderly patient. So most of the time above 60, known atrial fibrillation, coming to you with a sudden onset of central periumbilical pain, gradually getting worse, profuse vomiting and diarrhea. And then when you examine the patient, you found that there is periumbilical tenderness, rigidity, and rebound tenderness. At some point, patient also will have absence, bowel sound, and even shock can develop. But it takes some time. So if you suspect a patient to have acute mesenteric ischemia, what will you do? If you say that the patient is getting into shock, let's say unstable patient. For unstable patient with a suspicion that it could be mesenteric ischemia, you can't wait to do any investigation. In that case, you need to take the patient straight to the operation theater. But what if patient is still not in shock? You still have got some time. At that time, if you want to confirm the diagnosis, the best way to confirm it is CT angiography. Okay, so if you do a CT angiogram, the angiogram will be able to say where exactly is the block and what is the status of the gut. So that's our most likely investigation that we would do in such situation. Apart from that, if you do C-reactive protein, it will be elevated. If you do alkaline phosphatase, it will be elevated. Even if you do lactic, like serum lactate, that will be increased in this case. So management is surgical, like you have to send the patient for surgery in this case. Early diagnosis within a few hours is essential to save the intestine. Okay? Any questions so far, guys, with mesenteric ischemia? Moving on to acute urinary retention. So acute urinary retention is also common in elderly patients, especially male above 50 or 60, known prostatic problem. They can get urinary retention quite easily. CT angiogram or mesenteric angiography is the same thing. So although it is written in here that mesenteric arteriography is performed if emboli is suspected. So we say that CT scan gives the best definition while mesenteric arteriography is performed if emboli is suspected. So if you suspect that it is due to atrial fibrillation, then yes, mesenteric arteriography will be the best. If it is not due to an emboli, then CT angiography would be best. But most of the time, because arteriography, it's an invasive procedure, whereas CT angiogram, it's a non-invasive procedure. So we normally prefer to go for a CT angiogram because it is non-invasive. No, you don't need to go for laparoscopy. You don't have you can't, because the problem is that you need to save the gut. You need to remove that emboli. But at some point, maybe people will be able to do a laparoscopic removal, but at the moment, not yet. So the investigation is if you see the patient is in shock, then you can't wait. You have to take the patient for laparotomy. If patient is not in shock, then your investigation of choice will be CT angiogram. Okay, but if the question give you it's a known atrial fibrillation patient, and then they're giving you what is the best test. Then for suspicion of emboli, so if you suspect emboli, then mesenteric arteriography is the best. Okay, so retention of urine. So retention of urine occurs when more than 600 ml of urine is in the bladder. So when there is retention of urine, what is the problem? Problem is patient has the urge to go to the toilet to pass the urine, but they can't because something is obstructing the urethra, right? So because of that, there is accumulation of urine into the bladder, which causes severe lower abdominal pain. So patient will come to you like a known BPH patient who has benign prostatic hyperplasia. Let's say 56-year-old known BPH patient coming to you with a sudden onset of severe suprapubic abdominal pain. And when you ask the patient that when was the last time you passed your urine, patient says 12 hours ago. That's the time you would think that, well, it could be a retention. Because most of the time there is an underlying cause. So try to find out what's causing this. So apart from the common cause of enlarged prostate, it can also result from bladder neck obstruction by fecal loading. Many dementia or senile elderly patients can have chronic constipation. And because of lots of fecal loading into the rectum, it can press the bladder neck and it can also cause this retention. Okay. Sometimes it could be due to anticholinergic drugs causing the retention. Now, how to manage a patient who you suspect that it could be a retention of urine? The first thing that you can do is if you have a bladder scan, there are in hospital you will get a bladder scan everywhere. So bedside bladder scan. So first of all, you can confirm the retention of urine by doing a bladder scan. Once bladder scan confirms the diagnosis, if you know that this is a senile elderly patient or dementia patient, and the patient did not open the bowel for 3-4 days, so known constipation, in that patient you will perform a pararectal exam and you will try to feel that if there is any fecal impaction. If there is fecal impaction, you will empty the rectum. So you can do manual disimpaction or you can try some enema. If it is not fecal loading or impacted feces or fecal impaction, the next thing is that means it is not constipation. So what it is? Most likely it is the prostate enlargement. But you need to relieve the pressure. So you insert a catheter to relieve the obstruction and you drain it. Once the urine comes out into the bag, you send that urine for microscopy and culture to rule out any infection. Okay, so that's usually what will you do in this kind of urinary retention. So first you can do a bladder scan to confirm, and then you find out if the patient can have a fecal impaction. If it is, then you try to remove it. If no fecal impaction, then you insert the catheter, drain the fluid, drain the urine, and then send the urine for routine microscopy and culture. And then try to find out the cause. So if it is benign prostatic enlargement, find out that how big it is, and then send the patient to a urologist for consideration of a TURP, which is transurethral resection of prostate. Okay, and because patient needs to wait for some kind of surgery, before that you can try some medication to shrink the prostate, which could be like any of the alpha blocker like tamsulosin, prazosin. Those will be the drug of choice. There are new medication at the moment which has combination, which we will discuss during our prostate class. Yeah, bladder scan is ultrasound. That's right. So the question that you have shared, Dr. Shiria, there are lots of other options available. Now that you know the step-by-step management, so if this patient most likely having a retention because of no bowel movement, so you need to do a parectal exam in this patient, and I'm sure there is such option in there. No need, because if there is fecal impaction, then you might not even need to insert the catheter, because once the feces is out, then patient will pass the urine normally. So you don't need to even do the catheterization. That's why you take it. Okay, and that's why you try to rule that out, because it's not very comfortable for anyone to have a catheter unless the patient really needs it. Acute appendicitis in adult. So acute appendicitis is not uncommon in young adult. It can affect anyone at any age. It is the commonest surgical emergency. Okay. So how the patient usually presents? So usually patients under 30, they come to you with a central abdominal pain. So periumbilical pain. Pain gradually starts to become continuous pain, and then within 6 hours, it shifts from the umbilicus to the right iliac fossa. The pain can get aggravated by walking, coughing. After the pain, there will be anorexia, nausea, vomiting. So it is the pain which starts first, and then anorexia, nausea, vomiting. All right. Sometimes even questions come that what is the order of symptom in acute appendicitis? So order of symptom is first abdominal pain, then anorexia, then nausea, vomiting. So if you examine this patient, they will look distressed because of the pain. You can also get fever and tenderness in the right iliac fossa, especially at the McBurney's point. So all of you know what is McBurney's point. So over here, patient can get guarding, rigidity, rebound tenderness, which is very common. Especially rebound tenderness is very common in appendicitis. You can also get some of the sign positive, like Swas sign, obturator sign, or Rovsin sign. You don't need to know what these signs are. Just remember this sign can be positive in appendicitis. If you do a parectal exam, it will be extremely tender. That's one of the very important findings for appendicitis. So what investigation you would do? Most of the time, it is a surgical emergency. So if everything goes right, like patient has got typical abdominal pain, so right iliac fossa tenderness, especially McBurney's tenderness, everything goes clinically, everything goes like towards appendicitis, then you don't need to even do any investigation to confirm it. You can send the patient to the surgical, like you will send the patient to the hospital for a appendicectomy directly. You don't need to even do any investigation. But if there is a suspicion that you are not sure, then the best investigation that you can do a blood test where you will get leukocytosis, which is very common with raised CRP. If you do an ultrasound, it can sometimes confirm the diagnosis, but the best test will be CT scan. So CT can, most of the time, like 98% cases, it can confirm if it is appendicitis or not. Okay? So question comes in this way. They give you scenario that where you suspect appendicitis, and then they ask you what is your best appropriate management, or what is your most appropriate investigation in such patient. Most appropriate is CT. Even on the top of the blood test, CT is the most appropriate. Now let's say what is the next most appropriate, blood or CT? CT, because blood test will not confirm you the diagnosis. There might be hundred of causes why the patient has got leukocytosis or high CRP. Okay, so it's not going to give us many information. So ideally, our next most appropriate, everything should be a CT abdomen. Okay, if patient is pregnant and you suspect appendicitis, then we will go for an ultrasound because ultrasound will not have any radiation. Okay, otherwise CT is best. Management, definitely referral for surgical removal is the gold standard. Okay, clear everyone. So Dr. Shia, if there is a bladder scan and DRE, so again, bladder scan is not the most important thing. So if the question says already that the patient did not pass any urine for the last 12 hours, or if the question already mentioned that this is a urinary retention, then why would we do a bladder scan? That's our question. So if we are not sure if there is bladder, like if there is retention or not, like the question that you have shared, it already says that patient having acute retention of urine. So if we already know urinary retention, what's the point of doing a bladder scan? If we don't know, then we do a bladder scan. No, we don't need to do a MRI for appendicitis in pregnancy. We will do just an ultrasound. That's enough. Next, small bowel obstruction and large bowel obstruction. So this is very important for exam. So bowel obstruction, there are few symptoms that will help us to know that what kind of bowel obstruction it is. So there are four main features of bowel obstruction. One, abdominal pain. Two, nausea, vomiting. Three, absolute constipation, which means no passage of flatus even, and abdominal distension. How this starts, it gives us an idea that is it small or large. Small bowel obstruction because it's a bit like on the upper part of your tummy. Small bowel obstruction starts with abdominal pain and vomiting. After that, then the patient starts to get constipation and distension. So the pain and vomiting starts first, followed by distension and constipation in a small bowel obstruction. Exactly the opposite will be found in large bowel obstruction, where patient will have absolute constipation and distension first, and then later on patient will get pain and vomiting. So this is one of the way to know from the symptom that if it could be like a small or large bowel obstruction. So small bowel obstruction, the most common cause is adhesion. So patient might have a previous laparotomy or previous abdominal surgery. Following any abdominal surgery, adhesion can develop. And with those adhesion, small bowel obstruction can be a complication. So to think of small bowel obstruction, most of the time in the option, in the STEM, you will find out that patient had some previous abdominal surgery. It's a very common clue. Apart from adhesion obstruction, sometimes could be foreign body, gallstone, intussusception, malignancy, not very common, but it can also cause a small bowel obstruction. Clinical feature, patient will have severe colicky pain, especially epigastric and periumbilical. So like over here, because it's a colicky abdominal pain, pain will come sometimes every 3 to 10 minutes, lasting for a minute and then gone. Vomiting will be there, so these two comes first, and then it follows absolute constipation and abdominal distension. Okay, if you examine this patient, you can sometimes get like a visible peristalsis, tender abdomen, you can get increased bowel sound. So all of these can be found in your examination. If you do a parectal exam, it will be empty rectum. So once you suspect that it could be a small bowel obstruction, what will you do next? Your next choice of investigation is erect abdomen. So if you do an erect X-ray abdomen, you will get a step ladder pattern and you might also get a air fluid level. So let me show you how it will look like. So small bowel obstruction, it will always be in the middle or central part. And you will get this step ladder pattern where you see that in the middle, see these lines? These lines are called volvuli conniventis. And these volvuli conniventis, they are equally spaced, and the line traverses the whole bowel length. Okay? So this is large bowel obstruction where you get this step ladder pattern of air fluid level. So that's how a small bowel obstruction usually presents. If you see on the right hand side, like on this side, this is large bowel. And definitely it is bit of peripheral, right? So you can see how big the cecum is. And in here, you don't get this volvuli conniventis, but you get haustral folds. The haustral folds, they don't traverse the whole bowel lumen. They just like do a little bit. And they are not equally spaced also. So these are what we call as haustral folds. And if you look over here, that this is the like definitely dilated loop of bowel. And after this, there is nothing. So there should be some other gaseous shadow over here. But there is total empty rectum. So empty rectum is one of the very important finding of bowel obstruction. Okay. So that's how we differentiate the X-ray of large and small bowel obstruction. You can also see on this side how well you can visualize this step ladder pattern. See the step ladder pattern all over here. So that's a small bowel obstruction, how it looks like. Okay, now let's say you have done the X-ray, and in the X-ray you have got this specific pattern and you can confirm the diagnosis. But sometimes you are not sure that if it is a small or large bowel obstruction. In that case, according to JM, it says that you can do a gastrographin follow-through. Gastrographin is a water-based dye that can confirm where exactly is the block. So JM says to do the gastrographin follow-through, but it's very rarely nowadays we do this gastrographin. So most of the time, we will do a CT scan of the abdomen if we are not sure that if it is like a small or large bowel just from the X-ray. So your initial is X-ray, and the best could be either gastrographin follow-through or CT. So what is the management? So for a small bowel obstruction, your main management is first stabilize the patient. So nothing per mouth, IV fluid, and most importantly, this patient keeps on vomiting. So the most important thing is nasogastric decompression. So you put the nasogastric tube in and you decompress the bowel so that patient doesn't vomit anymore. And then even after some conservative management, it's not getting any better, then surgical repair will be needed. No measurement of gut diameter is needed, Dr. Tan. And X-ray followed by CT is the ideal. But if CT is not in the option, then you go for gastrographin follow through. Next, large bowel obstruction. So large bowel obstruction, as I said, that the patient with large bowel obstruction, they starts with absolute constipation and abdominal distension first, and then they start to get abdominal pain and vomiting. So vomiting is the last thing large bowel obstruction will get. So the patient will present with, like, they will have the same colicky abdominal pain. Pain will be hypogastric, so over this area. So hypogastric, absolute constipation, vomiting even might be absent or late presentation. If you examine this patient, you get increased bowel sound, abdominal distension can be marked, and local tenderness can be there. In parectal exam, you will get empty rectum. And again, if you suspect that if it is large bowel obstruction, your initial investigation will be X-ray. So what are the causes of large bowel obstruction? The most common cause of large bowel obstruction, especially in middle-aged and elderly, in 75% cases, colorectal cancer. So if there is a patient with large bowel obstruction, your first thinking should be that there might be a cancer which is causing this obstruction. What else can cause it? Sometimes sigmoid volvulus or cecal volvulus can also cause it. Sigmoid volvulus is common in older patients, and it is quite sudden and severe onset. Whereas patient with colorectal cancer who gets large bowel obstruction, it's a bit of insidious onset. So they have a history of 1 or 2 months of constipation, and then they start to get the pain and everything. So it's an insidious onset in cancer. Whereas if it is a volvulus, it becomes very sudden and severe. And it is common in dementia patient or nursing home patient who are bedridden. Okay. Now, when we get a patient with large bowel obstruction, you have to also rule out a possibility of a functional large bowel obstruction. The functional large bowel obstruction means there is no actual obstruction, but there is lack of peristalsis causing the obstruction. But the presentation will be exactly same like large bowel, but if you do all the investigation, you will not find any obstruction. So that is what we call as acute pseudo obstruction or Ogilvie syndrome. Okay. So that's where the problem is. Let's say you have done the X-ray, an X-ray showing dilated loop of bowel, postural folds. So you think that this is large bowel obstruction. How will you confirm that if it is pseudo obstruction or actual obstruction? Then you follow this chart. So you suspect large bowel obstruction. You did a plain X-ray abdomen, and you found distended colon, and you know that it is large bowel obstruction. Once you get that, to differentiate between a mechanical obstruction and pseudo obstruction, you do a gastrographin enema. The gastrographin enema will be able to actually show that if there is any obstruction or not. So let's say gastrographin enema says that yes, there is a mechanical obstruction. The most likely cause of mechanical obstruction is colorectal cancer. So then you do a colonoscopy and find out if there is a cancer or not. What else can cause mechanical obstruction? Sigmoid or cecal volvulus. So if it is sigmoid volvulus, the X-ray finding will be totally different. So this is how a sigmoid volvulus will look like. So if you see that this is kind of an inverted U-shaped, or you can say inverted tire-shaped thing, or even sometimes we say coffee bean, okay? So that's how sigmoid volvulus looks like. So this is sigmoid volvulus, this is cecal volvulus. So how to differentiate between these two? The symptoms will be totally same. So the only way to differentiate is that if we see that this is the long axis, if the long axis is towards the right side, this is the right side. If the long axis is towards the right side, that is sigmoid volvulus. And now this is the long axis. If the long axis is towards the left side, that is cecal volvulus. Okay. So That's one of the way to differentiate. Otherwise, it is very hard. So this is important because if it is a volvulus, you need to know that is it sigmoid or cecum. If it is sigmoid volvulus, the treatment is endoscopic decompression. So you decompress this volvulus or this abnormal kinking of the bowel by endoscopy. So endoscopic decompression is your first treatment. And if that fails, then surgery. If it is cecal volvulus, then you have to go directly to surgery because cecal volvulus usually will not be like possible to decompress by endoscopy. Okay. Now, let's say that you did the gastrographin enema. There is no obstruction that you could find out. That means it was a functional obstruction or a pseudo obstruction. Pseudo obstruction can be due to a lot of conditions. So I would like you guys to go to MedBullets and read about this pseudo obstruction. And also even you can go to eMedicine or Medscape to get some idea. So there are lots of causes of pseudo obstruction. One of the cause is medication like excuse me, levodopa carbidopa, like which we use for Parkinson. So some of the medications are there which can cause this. If you say that there is no obstruction in the gut after gastrographin, and you confirm that this is pseudo obstruction, then you do. Now there is one other way. Even by looking at the X-ray, there is a way to say that it could be pseudo obstruction. How? In pseudo obstruction, you will be able to see gas in the rectum. Now, if there was any obstruction, you should not be able to see the gas in the rectum, right? So if there is a gas in the rectum, means that there is no obstruction. That's why there is a gas. So that's one of the way sometimes that we can know that yes, that it might be a pseudo obstruction. And again, empty rectum. In obstruction, like actual obstruction, there will be empty rectum because nothing can come into the rectum. But if the rectum is not empty, that means there is no obstruction, like at least no mechanical obstruction. Okay, so that's another way, but you have to confirm it with gastrographin anyway. Now, in pseudo obstruction, our first thing that we would do is we will attempt deflation with repeated rectal examination and rectal tube. So you insert a rectal tube and try to deflate this obstruction. If that does not work, then you try a prokinetic medication. Okay? And prokinetic medication sometimes can push anything like it can activate the peristalsis, okay, or it can push the stool or feces. Can anyone tell me one of the medication which is a prokinetic? Like especially for such case, neostigmine. Yes, metoclopramide, domperidone, these are all prokinetic, but for this case, neostigmine, physostigmine, these are usually the common one that we use. So you'll use the neostigmine and see that if it is getting better. If it's not getting better, then you'll need to go for colonoscopic decompression. Still not getting better, then you might need to go for a surgery, which is very unusual that you would need a surgery for pseudo obstruction. Okay, but most of the time it is repeated rectal tube deflation is the one that's successful. Sometimes prokinetic, or at last you go for colonoscopic decompression. So that's how we manage large bowel obstruction. Okay. For large bowel obstruction, the management is IV fluid. You Also, if the patient is vomiting, then you might need to do a NG tube suction, but this patient will need a surgery. What about CT abdomen for investigation? So sometimes if gastrographin is not there, you can do a CT abdomen. So we do CT abdomen many times because like it depends on the X-ray. If X-ray doesn't give us too much information, then we go for CT sometimes, even before gastrography. But gastrography is the confirmatory investigation for large bowel obstruction. We don't go for enema in pseudo obstruction. Next, perforated peptic ulcer. So peptic ulcer perforation, all of you know about this. Peptic ulcer perforation comes as a severe acute abdominal pain. Sometimes patient might not even know that they had a peptic ulcer. So with or without a history of peptic ulcer, sometimes a patient can come to you with a perforated peptic ulcer symptom. It's a surgical emergency and it requires immediate diagnosis. Many times it could be due to long-term intake of NSAIDs. So let's see how it usually presents. Patient will come to you with a sudden onset of severe epigastric pain. Have a look in here that there is usually no back pain. So sudden onset of severe epigastric pain. Pain is not colicky pain, it's a continuous pain. It starts in the epigastric area first and then it becomes generalized to the whole abdomen. Pain can radiate to one of the shoulders or to the right lower quadrant, not to the back. And then delayed onset, like after the pain, patient can get nausea, vomiting, heat cough, those things can happen. But it's the epigastric pain, sudden onset, going to the shoulders, and also patient having generalized abdominal pain in few hours, that will give you the diagnosis. If you examine this patient, that actually confirm a lot of findings. Patient will lie quietly because even a sudden movement can make it worse. Pale, sweaty, and this is the most important line, guarding with a board-like rigidity on the abdomen. Okay? No abdominal distension. Bowel sound will be absent. Initially, pulse, blood pressure can be normal, but later on, patient can go into shock. If you do a parietal exam, patient will have extremely tender pelvic area. How to investigate this patient? So your initial investigation will be erect chest X-ray. If you do a chest X-ray, you'll be able to see something like this. So you'll be able to see gas under the dome of diaphragm. Now this is diaphragm. So this is the stomach area. So on the left side, a bit of gas is fine. It is normal. But on the right side, that is pneumoperitoneum. So just under the dome of diaphragm, you can see this gas shadow. That's pneumoperitoneum, which means perforated peptic ulcer or gas in the abdomen. So when you got that finding, it is enough to confirm the diagnosis. But if still you are not sure, either you can do a CT scan, which is more preferable, or gastrography in male. Again, CT is more preferable and it is more available. So usually after X-ray, if you want to confirm it, you do a CT. Management, nothing per mouth. Pain relief is very important. IV fluid, NG tube insertion, broad spectrum antibiotic, and immediate laparotomy. Okay. So that's your peptic ulcer. Now moving on to ureteric stone. Very, very important for exam, and there's a lot of confusion about this. So ureteric colic or ureteric stone. So even though it says colic, it is actually not a colicky pain when you have got the ureteric stone. So it is a constant pain due to a stone lost at the ureter. So patient can have a stone either in the kidney, they can have it in the ureter or in the bladder. So how a ureteric stone or kidney stone patient usually presents? So patient will come to you with an intense colicky pain. So it looks like a colicky pain, but it's not a colicky pain. So why it is colicky? Because every time the stone moves a bit down, it irritates or damages the wall of the ureter, and it causes like a little bit of extreme pain. So it's a colicky pain which starts in the loin or flank. So it starts on the flank and then it radiates down to the growing thigh, testis, or vagina in female. So that's a classic presentation. So a patient coming to you with a sudden onset of severe colicky pain, starting in the flank or loin and radiating to the growing thigh, testis, or labia with or without vomiting. That will give you the diagnosis that it is a renal stone or ureteric stone. When you examine, patient might be restless due to pain. You can also get costovertebral angle tenderness and sometimes hematuria. Now, the investigation is the one that comes in exam. Very, very important. Now, if you have got a patient who has got features of ureteric stone or kidney stone, you don't wait for any other investigation. You don't go for urinary microscopy culture. You don't do X-ray. You immediately send the patient for a CT KUB, which is like just a non-contrast. A spiral CT KUB is the gold standard. Okay, so your initial test, your next most appropriate, everything in a suspected ureteric or kidney stone is this CT KUB. Now, this is where a lot of people make it wrong. They do X-ray, ultrasound, everything, but that is not what guideline says, and that is not what we do in Australia. The reason is that X-ray sometimes can give a false negative result because X-ray cannot see the radiolucent stones. Okay. Ultrasound, sometimes it can be very hard for an ultrasound to get those kind of tiny small stones. But if your patient is a pregnant patient, you will consider doing an ultrasound rather than CT. So what is the point of doing an X-ray? The only point of doing an X-ray is that if your CT KUB shows that this is a radio opaque stone, you also do a plain X-ray to know where exactly is the stone on the X-ray. So next time, if you are sending the patient home, just to review that if the stone is getting out by itself, then you like let's say after a week, you just do an X-ray to see that if the stone is still there or it has gone down or it has changed at all. So X-ray is done to follow up, not to diagnose. Okay, sometimes we do both X-ray and a CT KUB, and only thing that we do is that X-ray when the patient needs a follow-up. Does it make sense for everyone? Okay, very good. Now, what will be the initial management? So initial management is once you know that this is a stone, the stone management depends on a lot of factors. It depends on where exactly is the stone, how big is the stone, and if it is causing a full obstruction. But the first thing is that you need to make the patient pain relief. So pain relief will be your first thing. So you give them some good painkiller like IV morphine, fentanyl. Okay, this usually will be the first line. And then you ask the patient to increase the water intake. most of the time, after a bit of pain relief, the pain usually will be settled and patient can go home if the stone is not really big. Now, the management. So the management of a stone depends on a lot of factors. It's not well written in JM. JM says that the stone is likely to pass spontaneously if it is less than 5 millimeter. If it is more than 7 millimeter, then usually intervention will be required. Okay. Now let's have a look. We say that up to 7 millimeter, and if it is non-obstructing ureteric stone, and patient doesn't have that much of a symptom, you can wait. You can wait for the stone to come out by itself. Okay. But if a stone is more than 7 millimeter, then the management usually will be done, especially if the patient is symptomatic. It's not avoid fluid, so avoid high fluid intake. So what happens that patients who gets this kind of stone, there is a myth that you need to increase like amount of fluid and then it will pass out. So they do a lot of, like, if your water intake is that high that you are just causing distension of the ureter, because of that it can cause more pain. So we say you don't need to like take 5-6 liter of water, just take 2 to 3 liter water, which is normal intake. So the kidney stone, the management is different in a lot of guidelines. And I strongly urge everyone not to follow any other guideline except what is written in here, because this is from RACGP guideline. Even JM did not explain really well that when we are doing in like intervention. So according to this, especially the RACGP says that if the stone is in the kidney and if it is less than 2 centimeter but more than 7 millimeter, then you need intervention. The intervention will be laser lithotripsy. Okay. So laser lithotripsy means using the laser, you are just going to break the stone into multiple smaller stone and then it can come out by itself. Sometimes, like previously, shock wave lithotripsy, which is extracorporeal shock wave lithotripsy, ESWL, the shock wave was a very common method of treatment long time ago. But nowadays, this is rarely that we would use. The only indication it can have that if the stone size is less than 1 centimeter and it is in the renal pelvis or calyx. In other cases, we will go for laser lithotripsy. Okay. If it is more than 2 centimeter, it is very hard to manage just by laser. In that case, the patient will need a percutaneous nephrolithotomy, which is surgery. Okay. What about ureteric stone? RACGP says whether, like wherever the stone is, either a stone is in the proximal 1/3, middle 1/3, or the lower 1/3 of the ureter, doesn't matter. Laser lithotripsy is the treatment of choice. Okay, so ureteroscopic laser lithotripsy, that's usually will be the main management for any kind of a stone. Except if it is a kidney stone, it will be PCNL or percutaneous nephrolithotomy. There is a condition called staghorn calculi. So the stone will look like this. If you get a staghorn calculi, doesn't matter what is the size of the stone, that will require a surgery, okay? Or PCNL. So a staghorn calculi, it's always surgery. In other cases, it depends on the size and site of the stone. Okay. So this is like one of the other three things when to refer: a stone size more than 7 millimeter, high grade or bilateral obstruction, hydronephrosis, patient having severe pain, stone is not progressing after a few weeks. So in this situation, you need to send the patient to the urologist for further checkup. Okay, so that's all about urinary colic. We're going to take a 10-minute break now, and after that, we will restart with the biliary pain and like a cholecystitis. Which want to repeat, Dr. Mahfouza? So if you're asking about the stone, less than 2 centimeter kidney stone, you go for laser lithotripsy. More than 2 centimeter PCNL, and for ureteric stone, you go for laser lithotripsy. So most of the time, it is laser lithotripsy. Ten-minute break. All right, everyone, let's continue. So we finished up to this, starting with the biliary pain. So biliary pain means it's coming from the gallbladder. So, so most of the time it is a gallstone which causes this biliary pain. It's common in female 40, fat, fair, and fertile, but it can be there in any patients. It's not always like this. So how this patient usually presents? Patient will come to you with an acute severe pain, especially in the right upper quadrant or epigastric area. So just over this area, patient will have a severe pain, colicky in nature. Now, sometimes this biliary colic pain can last for 2 to 3 hours as a constant. So not always like it's a colicky pain. Initially, like when there was a gallstone, then it could be just a colicky pain. But when the gallbladder gets inflamed, like a cholecystitis, it becomes a constant pain. So you get a patient who is coming to you with an acute severe pain in the right upper quadrant, and it is started after eating meal, so postprandial, constant pain, and then there is tenderness in the right upper quadrant. Sometimes the pain can radiate to tip of the right shoulder or scapula. And then along with that, they can also have a bit of nausea, vomiting. So let's say that if we are thinking about acute cholecystitis, okay, not just a biliary pain, we are thinking about acute cholecystitis. So patient will have the same features that we are talking now. So sudden onset of severe right upper quadrant pain, bit of fever sometimes, and then nausea, vomiting. And when you examine the patient, there is severe tenderness in the right upper quadrant, and your Murphy's sign, like Murphy's sign, will be positive. So if Murphy's sign is positive and all the symptoms goes with it, then it is acute cholecystitis. What will you do next? For acute cholecystitis, your initial investigation should be abdominal ultrasound. Most of the time, ultrasound is able to confirm the diagnosis. If it is not sure, then you go for a CT abdomen. Okay? So how to manage acute cholecystitis? So first of all, you need to give some pain relief. So give them pain relief, either morphine, fentanyl, or ketorolac. And then you can also put some IV fluid, nothing per oral. And if it is a cholecystitis that needs cholecystectomy, laparoscopic, which is the common one at the moment. So patient will need a laparoscopic cholecystectomy. Okay. So this is where they have discussed about acute cholecystitis. So the treatment is bed rest, IV fluid, nothing per mouth, analgesics, antibiotic, and cholecystectomy. Moving on to acute pancreatitis. So acute pancreatitis, its most common cause at the moment is history of alcohol. Although in JM it says gallstone is more common, in Australia or in the Western countries, alcohol is the main cause of pancreatitis, followed by gallstone. So how this patient will present? Patient will come to you with a sudden onset of severe constant epigastric pain, and the pain will radiate to the back. Relieved by sitting forward, associated with nausea, vomiting. If you examine this patient, there might be a bit of tenderness in the epigastric region, but there will be lack of guarding, rigidity, and rebound. Very important to understand this, because acute pancreatitis, the symptoms will look very severe. But when you examine the patient, there might not be much of a finding. Maybe a bit of tenderness in the epigastric region. Other than that, everything looks really good. Okay? If you want to diagnose this, your initial investigation should be a blood test, which is serum lipase. So serum lipase or amylase is the main investigation or initial investigation. And then if serum lipase is very high, that confirms the diagnosis of acute pancreatitis. You don't need to do any imaging to confirm it, just a blood test. Okay? Now let's say that if you are looking for a complicated pancreatitis, or the patient doesn't get better. Rather, over the next 2 to 3 days, a acute pancreatitis patient getting worse. That's the time you do a CT scan. So you don't do CT scan initially to confirm pancreatitis, but if there is a complication or in 2 to 3 days time, it's just getting worse and worse, then you do a CT. Okay, very important to know this. So management, hospitalization, bed rest, nothing per mouth. You can give them IV fluid and some analgesics. So it's just conservative treatment. Okay, and usually it will get better. Then acute diverticulitis. So acute diverticulitis is common in like a middle-aged patient. So acute diverticulitis is usually above 40 years of age, and they usually give you a history of constipation. Okay. Now, Dr. Majeda, if you want me to repeat anything, or any of you want me to repeat anything, just explain specifically what you want me to repeat, because there is a lot that we need to discuss for GIT. We can't repeat the full thing again because we don't have that much of a time. Okay, I hope you guys understand this, because like if we finish acute cholecystitis, I can't repeat the acute cholecystitis again, but I can repeat anything that is you don't understand, like what is the investigation or something specific. If you don't understand, just let me know. But the full thing cannot be repeated, okay? Because we don't have that much of a time to finish. So acute diverticulitis means, you know, that sometimes what happens that if a patient has long time constipation, they can develop this kind of finger-like projections. So let's say that this is the cecum, and then this is the sigmoid colon. The sigmoid colon, sometimes long-term constipation patient, they can develop these finger-like projections in their colon. These finger-like projections, it can then accumulate feces or stool. And stool definitely is a good media for bacteria. So sometimes these stool or these finger-like projections, which are called diverticula, they can get infected, causing acute diverticulitis. Okay, so that's the main way of having diverticulitis. So long-standing constipation and a left iliac fossa pain is common. So how the patient will come? Above 40, patient coming to you with a sudden onset of left iliac fossa pain. The pain can get worse with walking or change of position, usually associated with constipation, and the patient will have systemic features. So fever, nausea, vomiting is very common. So the sudden onset of left iliac fossa pain, tenderness, history of constipation, and also patient having fever, nausea, vomiting, that is acute diverticulitis. How to examine this patient? So when you examine this patient, you will get guarding and rigidity in the left iliac fossa. And once you know that this is most likely diverticulitis, you will investigate the patient. First, you do a blood test. So blood test will show you leukocytosis, elevated ESR, CRP, and your best investigation is a CT scan. Okay. So again, if they give you a features of acute diverticulitis and they ask you what is the next most appropriate investigation, CT abdomen will be your most important investigation that can confirm the diagnosis. And along with the CT, you can do some other blood tests and everything. Okay. Once it is diagnosed as diverticulitis, patient needs hospitalization, nothing per mouth, and then it's just a wait and see approach, but you need to give them painkiller and antibiotic. If it is mild case, you can give oral amoxiclav, or if patient cannot tolerate penicillin, then cefalexin plus metro. If it is severe, like patient is unable to eat, vomiting, very unwell looking, then IV amoxicillin, gentamicin, and metronidazole. So mild cases, which is most of the time it is mild, so we give augmentin or amoxicillin clavulanic acid, or if patient is allergic to amoxicillin or penicillin, then you give Metro plus Keflex. If it is severe, then IV ampicillin or amoxicillin plus Genta and Metro. That's all about acute abdomen, guys. It's a huge chapter. We always struggle to finish it, but there is a very, very important topic that you need to know. So acute pancreatitis, the investigation, initial or your main investigation is serum lipase. And if you suspect complications, like let's say if you're thinking that after 2 to 3 days, pancreatitis should get better, not worse. So if it is getting worse, then you do a CT abdomen. And for pancreatitis, there is no requirement of antibiotic. It's just like nothing per mouth, IV fluid and analgesics. Cholecystectomy following pancreatitis only needed if that is caused by gallstone. So once pancreatitis is a bit better, you send the patient for an ultrasound of the abdomen to look for any gallstone. If the gallstone is there, that could be a cause of pancreatitis, then yes, you are going to go for a cholecystectomy. Moving on to our next thing. So ureteric stone treatment. So if it is ureteric colic, Dr. Mahfouza, so first of all, you will need to give them painkillers. So strong pain relief is the main treatment for colic. But if you are talking about a stone, the treatment depends on the size of the stone. If it is less than 7 millimeter, you allow the stone to pass spontaneously. There is nothing you need to do. It will pass on its own. More than 7 millimeter, unlikely to pass. In that situation, the patient will need a laser lithotripsy. Now, there are a few other things that we will go through very quickly. Sometimes there are investigations or a scoring system that we use to predict the severity of acute pancreatitis, which is called Ranson score. You don't need to memorize the score, but just remember that what are the findings that we can get in a pancreatitis patient. So pancreatitis patient, definitely it is infection. So white blood cell will be up. You can get hyperglycemia, liver impairment, serum LDH can go high. And then sometimes this patient calcium can be low. So hypocalcemia, blood urea nitrogen can get high. So patient can develop renal failure. Okay, so that's usually what we can get. This is the best thing that you can get to remember. So if the patient has got 3 or more of these features in the first 48 hours, it indicates a severe pancreatitis. And the mnemonic is pancreas. So partial pressure of oxygen low, A's more than 55, neutrophil more than 15, hypocalcemia, renal impairment, enzyme abnormality like LDH and AST high, hypoalbuminemia, and hyperglycemia. Okay, so sometimes they say that which of the following is not a complication of pancreatitis. So you need to know what usually happens with called calcium, renal function, and everything. Okay, moving on to the next chapter, which is dyspepsia. So dyspepsia is in your John Murtagh. So that's in your chapter 36 in GEM 8. So let's start that. So dyspepsia means indigestion. And a lot of patients suffer from indigestion, which could be a lot of causes. But the main causes of dyspepsia can be reflux. Sometimes it can be peptic ulcer disease, okay, which will include gastric ulcer, duodenal ulcer. Sometimes it could be due to gallstone. So a lot of causes are there to cause dyspepsia. So in here, there are a few things that is written that burning discomfort means gastroesophageal reflux. Sometimes if food aggravate the symptom, could be gastric ulcer. So lots of things are there which sometimes helps us to know that what kind of condition it is. So give it a read. Now, not everyone who suffer from dyspepsia will require investigation straight away. Okay, so there are some red flag. If a patient has those red flag, that is the only time we would go for endoscopy in a patient who is having dyspepsia. One of the most important things is that sudden onset of dyspepsia or indigestion in a patient over 40, that is something concerning. So sudden onset in more than 40, that's one red flag. If it is getting really bad, even after you are giving medications like PPI, still it is getting really bad, that's a red flag. Dysphagia, that means swallowing difficulty, anorexia, unexplained weight loss, GIT bleeding like melena hematemesis, pain radiating to the back, pain waking up the patient at night. Any of this is there, okay? Any of this is there is a red flag. So when those red flag is there in this patient, you will go for an endoscopy. Endoscopy is superior in investigation of upper GIT than barium meal. We no longer do barium meal unless we really need to. So endoscopy or gastroscopy is the main investigation of choice. There are a few other things, like if you suspect the patient having a peptic ulcer disease, you can also check for Helicobacter pylori. How we do Helicobacter pylori test? There are some non-invasive and invasive tests. Non-invasive tests are, you can do a H. pylori or Helicobacter pylori serology to check for IgG antibody. This is excellent to diagnose the condition, but not for follow-up. Urea breath test, very good for follow-up. You can do stool antigen test. So that's all non-invasive. So either you do a blood test to check the IgG antibody, you can do a urea breath test, you can do a stool antigen test. Remember, once IgG antibody is positive, it will always be positive. So that's why it is not a good thing to follow up. But urea breath test positive means patient is active, like acutely infected with H. pylori. So if you're, let's say your patient previously had Helicobacter pylori, and now again you want to know that if it is infected right now, you can't do serology because it will be positive. So you have to do the urea breath test in that case. The invasive test that when you send the patient for endoscopy, they take a biopsy, and in that biopsy you can do H. pylori test, which is like you can do a H. pylori culture, or you can do a rapid urease test on that histology specimen. And that is the gold standard investigation to know about H. pylori. Okay, but most of the time we would do the non-invasive investigation. So first cause of dyspepsia is gastroesophageal reflux disease. All of you know what this is. So patient with gastroesophageal reflux, they come to you with acid regurgitation, reflux, heartburn, water brush. That means their mouth fills with saliva. Sometimes it gets worse at night time because at night times, because of gravity, the acid from the stomach can easily go up to the esophagus. So diagnosis is based on the clinical symptom and the history. So very rarely to confirm gastroesophageal reflux, you need an investigation. And you would not do it unless there is a red flag. So these are all the red flag for upper GIT endoscopy, which we discussed in here. So you can go through it. The complication with this reflux is that it can cause esophagitis, like inflammation of the esophagus. It can cause esophageal ulcer, and ulcer can bleed, can cause iron deficiency anemia. Sometimes because of chronic reflux, the lower end of the esophagus can change. So you know that like esophagus has squamous cell and stomach has columnar cell. So sometimes because of prolonged acidic reflux, this lower end can change into columnar epithelium, and columnar epithelium is more prone to get adenocarcinoma. Okay, so there is what we call as Barrett's esophagus when there is change of mucosa in the lower end of the esophagus due to prolonged acidic reflux. The concern with Barrett's esophagus is that there is a risk of cancer. Okay? So Barrett's esophagus is a metaplastic response to prolonged reflux. It's a pre-malignant condition prone to ulceration. So this patient usually needs long-term PPI to control the symptom, and they usually need a 2 to 3 yearly endoscopy. Nowadays we do 3 yearly endoscopy, but according to JAM it is 2 yearly endoscopy. So that comes in exam a lot. Okay. So ideally for gastroesophageal reflux, we don't need to do any investigation except there is a red flag. If there is a red flag, then you do endoscopy. What is the confirmatory test to diagnose reflux? The confirmatory test is this one. It's called 24-hour esophageal pH monitoring. That is the gold standard. Management. So most of the time, initial management is just patient education, lifestyle modification. So reduce weight, reduce smoking or alcohol, avoid fatty food. So few lifestyle and dietary changes are needed. If there is no relief after several weeks of lifestyle modification, then the treatment of choice is proton pump inhibitor for 4 weeks. So you can use any of the common proton pump inhibitor for 4 weeks and see how it goes. There is no need of going from like antacid, then H2 receptor blocker, and then PPI. It's no longer that we need to do this thing. We can directly go into PPI from the start. Okay, now there is not much in the notes, so we'll move on to chapter 36 just to see if there is anything else that we need to discuss. Do you guys have any questions so far? Now, moving on to dyspepsia, chapter 36. So we discussed a little bit about these things. You will definitely read the initial part by yourself. So we discussed gastroesophageal reflux disease, management, and everything. You don't need to know about these water-soluble, insoluble antacids. Antacids are rarely used anymore, so not very important to know about them. Mainly proton pump inhibitor is the one that we use. We talked about Barrett's esophagus. Peptic ulcer disease. Okay. So peptic ulcer disease is very common, not very common in Australia, but it is common. Duodenal ulcer is more common than gastric ulcer, and duodenal ulcer is more common in men. Lots of risk factors are there. So most commonly it is related to H. pylori or NSAID. So patient with ulcer, they present with a epigastric burning pain. related to meal. So if a patient coming to you with the episodes of epigastric pain, which feels like a burning discomfort after having a meal, that is sometimes what we will think of peptic ulcer disease. Indigestion, burping, reflux is also common in a peptic ulcer patient. Physical examination usually will not give you much of a finding, but it is the burning epigastric pain related to meal that gives you the diagnosis. If you think that this is peptic ulcer disease, then you have to confirm it by doing an endoscopy first. With the endoscopy, it will give you an idea that where exactly is the ulcer. Is it gastric or duodenal? And sometimes even they can take the sample and do the H. pylori test on that. Now, if you want to check for H. pylori in other way, then you either do a serology or urea breath test. That's usually the investigation that we do. Lots of complications are there for the ulcer, so it can perforate, they can have a bleeding, obstruction, anemia, lots of problem is there. Let's say we have got a bleeding peptic ulcer, which presents with hematemesis, which means vomiting of blood. So peptic ulcer, ideally the patient needs a endoscopic hemostasis with electrocauterization plus or minus injection of adrenaline. You will also give them IV omeprazole 80 milligram bolus dose. So bleeding peptic ulcer, first we give IV omeprazole followed by endoscopic hemostasis with electrocauterization plus adrenaline. Okay, so that's usually the treatment of bleeding peptic ulcer. So how will you manage peptic ulcer disease? So for peptic ulcer disease, first of all, you need to find out the cause. Is it H. pylori induced or is it H. pylori negative? If it is H. pylori positive, then you will need to treat them with triple therapy. If it is H. pylori negative, you just treat them with PPI. Now, after triple therapy, how we would know that the treatment is successful? So if it was a duodenal ulcer, you just confirm the eradication with a urea breath test. If it was a gastric ulcer, then you have to do a repeat gastroscopy. So that comes in exam. So if it was H. pylori positive, and then you did a triple therapy, after triple therapy, you need to confirm the eradication. So when you initially did the endoscopy, you knew that where is the ulcer. If it is gastric ulcer, then you need to do a repeat endoscopy to make sure the ulcer is gone. If it is duodenal ulcer, then you do a repeat urea breath test. So the triple therapy for H. pylori, the first line triple therapy is PPI plus clarithromycin plus amoxicillin. All of this you'll be giving twice daily for 7 days. That is usually the preferred regimen. If that is not working, especially if the patient is allergic to penicillin, you can't give them amoxicillin, then you do PPI, Clarithro and metronidazole. So this initial triple therapy did not work. So your next option will be changing the clarithromycin with levofloxacin. So you keep PPI and amoxicillin as it is, but you change Clarithro with levofloxacin. Still did not work, then you go for quadruple therapy, which is bismuth, PPI, tetracycline, and metro. Okay, so you need to know the antibiotic name, it comes in exam. For children with H. pylori, the treatment is same, PPI, amoxi, and Clarithro. If it is NSAID induced peptic ulcer, you have to stop the NSAID and the patient needs to change the NSAID to something simple like paracetamol and PPI for 4 weeks. Stomach cancer. We are always concerned about stomach cancer, especially if it is a new onset of dyspepsia. So consider if upper GIT symptom in patient over 40, especially with weight loss. Recent onset dyspepsia in a middle-aged patient, dyspepsia unresponsive to treatment. So basically, if a more than 40-year-old suddenly coming to you with indigestion, anorexia, they're having weight loss, okay, vague epigastric fullness, you would be concerned about a stomach cancer. Okay, so definitely you need to send the patient for a endoscopy. And endoscopy will be able to confirm the diagnosis. All good, guys. So that's all for tonight. So we'll finish with these 2 chapters today. And the next class we'll be doing constipation, diarrhea, and rest of the things that we are left with, which is hematemesis, melena. Those are not very hard to finish. The 2, which is constipation, diarrhea, is a bit large topic with dysphagia. These will be the 3 main topic that we are going to discuss in our next class. Okay. Sometimes we can't finish jaundice in the class because there is a lot to discuss. If we can't, then we keep it for our end of the course classes. Okay, so that's all about today, guys. Any questions that you have? Yes, dysphagia is quite important for AMC. We will discuss that. Our first thing to discuss will be dysphagia next class. All good? So no questions? Respiratory question solved class will be after the GIT class is finished. Then we will do both GIT and respiratory together. Yes, Dr. Ahmad, that is chest drain because it's a asthma, which means it's a secondary pneumothorax. And Dr. Faria, the class schedule has been given. Have a look in your Facebook group about the class schedule. Okay. All right, everyone. Seems like nobody has any questions. So we'll finish it here tonight then. Take care, everyone. Have a good night. Bye.